Salam sejahtera. Hai, Wanakkam. Saya Dr. G. So, hari ini dalam Health Talks kita akan berbincang mengenai role of physiotherapy. Okey, sekarang kita selalu dengar pasal fisioterapi, tapi kita tak tahu apa role of physiotherapy in many cases. Okey, so sebelum kita start, sebelum saya introduce my host, saya nak ingin mengucapkan terima kasih to the sponsor today, Dr. Life Hair Tonic, one tonic that helps with every solution. So, hari ini kita akan berjumpa dengan Mr. Nimalan, physiotherapist from Sun Rehab. So, hari ini kita akan berbincang mengenai role of physiotherapy in stroke patients. So, hi Mr. Nimalan.
Hello, Dr. Shita. Vanakkam.
Welcome.
Yes.
Okay, so please introduce yourself first.
Okay. Yes. As you told me, my name is Nimalan Arumugam. I'm a founder and senior physiotherapist from Sun Rehab. I have almost 10 years of in physiotherapy field. I got diploma, degree, and masters. And still practicing as a physiotherapist.
Okay.
Yeah, almost strictly following all the rules and work ethics as a physiotherapist.
Okay.
Yeah.
Amazing. Great. So, okay, we always hear that about physio, but most of the time we don't know what is the role of physio. Okay, especially when it comes to stroke patient. So, can you tell us what is the role of physiotherapy in rehabilitation of stroke patient?
Okay. It's a good question, Dr. Cheetah, because when we say physiotherapy, right, in bahasa physio adalah jurupulih anggota badan.
Okay.
So what people say is urut sudah datang. say so when people say when we say physio, people say urut
Okay.
ataupun exercise.
But it's more than that, right?
Yes, it's a overall we do rehabilitation.
Okay.
Before that, physio can overall physiotherapist can be a sport person, like gym trainer, sport physiotherapist, and also physiotherapists who can work in hospital or rehab centers.
Okay.
So can help people in all range.
Okay.
Okay, in a stroke rehabilitation, now it's very sad because most of the therapists now not focusing the actual stroke rehabilitation.
Okay.
Okay, when we say it is rehab, that means we retrain again.
Okay.
Okay, retrain somebody who able to do something but now cannot do.
Okay.
So that's how we help the stroke survivors. So
Okay.
normally we don't call as a stroke patients, we call them as stroke survivors.
Okay.
After an stroke episode, we try our best. We use various techniques of physiotherapy, which we have it in physio, to help the stroke survivors.
Okay, as a doctor, I'm very familiar with the word neuroplasticity, but a lot of people are not familiar with that word. So, can you please explain?
Okay. Thank you, Dr. Jivita, for asking for that. Neuroplasticity is a wonderful concept. It's actually an amazing concept where we used to retrain brain injury.
Okay.
Okay. For normal people understanding, right? Neuroplasticity is the ability for a person to learn a skill. Okay. So we learn any skill with neuroplasticity. Example, I give you a scenario. It's a real life scenario. Like, can you close your eyes? Okay. Now what you do? Imagine you're at entrance of your house. Okay. Now opening the door, and you are entering to the house, and suddenly there is no light. Okay, now it's totally black, right? Okay, now can you still imagine
Yes.
where is your sofa, your table,
Yes.
your TV arrangements? Okay, now you open your eyes. Okay, how you remember that?
Oh, I think my body is just used to it.
Yeah.
I have memory of it.
Yes. So you seeing that every day, you practice, you're observing that every day, and you are that every day. So it been registered in your brain with neuroplasticity. That's a
Okay.
concept. So what we do in physio, we do like stimulation or any methods that that create or organize to create a neural pathways in the brain.
Okay.
So when stroke happens, the injury it will affect that part, the neural pathways. So when we use neuroplasticity, it actually create a new pathways for these neurons to travel.
Okay. So, excuse me. So in that way, if let's say sometime or most of the time, a patient who has stroke survivors, they are not able to walk. So neuroplasticity helps them to walk again. Is that how it is?
Yes, like if you see, even now we hear news like 70 years old, a grandfather or grandmother still complete their studies. People achieve their like runs or any other achievements. How they do it? They practice. So
Yes.
when we practice, actually it can cause it's a new pathways in the brain. With that, the body can achieve.
Okay.
So in what happened in stroke, once the injury happened, so maybe one part of the body is not going to function as before. So this is a relearning. There's a difference, A person, elderly person, getting a stroke, where a young person getting a stroke. Even nowadays, babies getting stroke. Okay, so for elderly stroke is actually relearning of the task. That
Okay.
means what we're going to do, we're going to tell, like example, the person walking before and now got stroke, and now we're going to tell the brain, you used to walk, okay, it just now you can't walk, so we're going to push again and again until the brain learns and the person walks.
Okay. So how is it different with a younger patient and an older patient?
Okay, just now I gave you the scenario, right?
Yes.
Okay, that is in your house.
Okay.
How about if you imagine somebody else's house?
Difficult.
Yeah, the picture won't be in
As
your
clear.
mind, right?
Yes.
So I can't say my house because you've been to my house, right? So
Yes.
so that's why if like suddenly if same things happen, suddenly maybe here is blackout now, maybe you might don't know what are the things in front. So it not register in the brain. Same goes to baby. They baby or kids, they never learn any skills.
Okay.
Skills also such as like not only walking, okay, writing, like even like like driving also a skill.
Okay.
Okay, so learning is all will be affected, but for the babies, they don't have this.
Okay.
Okay, it's a progression. When they get when they grow up, they learn these skills.
Okay.
That's how it's different. So it easier to train a elderly stroke survivor compared to a younger one.
That was going to be my next question. Which one is
Yeah,
easier?
because as I told you before, in elderly stroke survivors, we're going to push the brain or force the brain.
Okay.
You've been doing this, now you just cannot do. Okay, now we are pushing you. Okay, but in the babies or kids, they never done that. But in babies or teens, it will be kind of a difficult. I won't say difficult, it's challenging, not only for the stroke survivors, for the therapists,
Physiotherapist
yes,
also.
to understand the emotion. Right, sometimes they will be same age with you or younger than you, so it will be sometimes questions they throw at us. It will be like sometimes it can be hurtful or it can make you emotionally sad. Like example, when you have like a 6 7 years old kid with affected limbs and legs, who can't tie his shoelace, he might ask you why I cannot tie my shoelace while my friends
And
can. So like what you can tell. So normally what we'll tell, okay, if you cannot tie shoelace, you can use with the Velcro. So when I suggested that to one of my client, he asked me back, why Nimal I cannot tie shoelace when my friends all using
can.
it, right? So I cannot answer. Like what you can answer, Dr.
Yes.
Jita? You tell me.
That's a
Right?
difficult position to
Yeah.
be.
And sometimes when we take the adults, elderly stroke survivors, they will ask you, "Are you sure can treat me or not?" Then some will ask you like, "You don't have stroke, so you don't understand me."
Yes, yes.
But then I'll say, "You go to doctor. Doctor also won't have that sickness, right?"
Oh my God.
So yeah, I'll push it back to the doctors.
See?
Yeah, but the thing
Okay.
is, we don't need to, have that situation
Yes.
to understand them.
True.
But that's why a good therapist always listen to their client. So that's how it will be different. And
Mhm.
the stroke treatment or rehabilitation will be totally different. The
Okay.
journey, every stroke journey is unique, but is the consistent,
Consistency.
so we need to work on that.
Okay. So for patients, if let's say a patient comes to rehabilitation immediately after a stroke, or a patient comes after few months after stroke, is there any difference?
Yes, it will be. Nowadays, like latest studies saying that you can start after 24 to 48 hours, you can start the rehabilitation.
Okay.
We can start with a basic rehab in the hospital. Nowadays, our Malaysian hospital also, they aware of this and they are starting it. It's very good. And we can put it as like acute, subacute, and chronic.
Okay.
Of course, chronic will be more than 6 months or 1 year period, which will be difficult. The earlier is the best.
Okay.
And also for the recovery, we check on how severe is the stroke. Okay,
Okay.
stroke, there is a three types. One is more like a burst, which is cause more symptoms and severity. And second is the blockage, and third one is more like a bleeding.
Okay.
Okay, so there is a difference with mini stroke and minor stroke.
Okay.
Okay, minor stroke is where the symptoms is lesser than the actual stroke,
Okay.
whereas mini stroke is actually only for 24 hours.
Yes.
After that, the symptoms won't present on. You can't see, but after a couple of months, the same client might have the actual stroke. That is a mini stroke.
Okay. So if like as for patient who come for because sometimes we are not consistent with our physiotherapy. So how would you suggest a patient how frequently should they go for a physiotherapy if they want to have a full recovery?
Mm-hmm. Okay, for recovery, what is recovery actually?
Okay.
For each patient is different. Okay,
Okay.
each person is different. Uh, and is the word on the stroke is only the same word. The rest is different. So the therapist must aware what this particular person needs in their life. Okay, for stroke rehabilitation, after neuroplasticity, the next word should be independence.
Independence. Okay.
How we can train this person to retrain or get back his independence. That's the only goal. So example, if a person affected with the right hand, okay, mostly we Malaysians, Asians, we have a culture of eating with the right hand,
Yes.
right? So we try our best. We will still do the rehab, but takkan we want to wait until the person get the right hand to eat, right? So we can start to train on the left hand. So to be independent. So to continue the life. This is what I learned from my previous company called NASA, as a National Stroke Association, where I say there is a life after stroke. So you need to push them, like as a therapist, you push them back to their life. So the rehabilitation will be different. That's why we in Sun Rehab we do like hybrid. We have a center, but we do house calls. So if you go to hospital or center, the rehab will be different. But when the therapists come to your house, there the rehab will be different.
Okay.
Okay, so it's most the goal will be get back to their life.
Okay.
If you ask like, do they have like 100% chance to recover? There is no. But if they push, if we push them, 95% maybe can get back with their motivation, good diet and food, the family's motivation, and good therapists. Okay, they can, and also most important is the severity of the stroke. We can push them back. So the therapists, whoever like trying to help the stroke survivor, don't see them as just a case, but you need to understand a person. Sometimes it will be different from different clients. You can't use the same methods for in stroke rehabilitation.
Okay, understand. So back to the question. How many times would you recommend?
The the more frequent you do, you can get a faster recovery or high recovery rate. That means even you can do every day.
Okay.
Yeah.
Because as for physiotherapists, usually you will teach the patients as well to do it at home by themselves, right?
Yeah.
So I think most of the time the most important thing is the patient's motivation. If you're motivated, you can do. If you do it yourself, I think the chances of recovery is faster and more. Okay. So what are the most common physiotherapy techniques do you use?
Okay. uh Sometimes talking also a therapy, Dr. Dilita.
Yes.
Right?
Okay. Yes, I
Okay.
will
So that is
accept.
the first. You need to, okay, the client must be they must trust you. Then only they will follow you. If no, they won't follow you. Okay. Techniques, we, even though now we are going into AI and robotics, there's still debates going on, right? Like AI going to replace therapists. I don't know about that. We'll talk that in a different podcast.
Definitely
Yeah.
can.
But now, to cut it short, is everything manual. Everything manual therapy. It says one good um, technique which we use is task orientated exercises or program or activities.
Okay.
We will do repetitive movement. Like example, I told you about the neuroplasticity, right? Some of the studies saying that we almost need to do 10,000 times to for the brain to remember certain activity uh, or skill. Okay, so for that we need to do again and again. So it's need to be task orientated. The difference with normal active movement and task orientated is like it's more focused. Example, I can say like this. Okay, can you please raise your hand?
Oh,
Yeah.
again.
Okay, this is one. Okay,
Okay.
can you raise and touch my hand? This is more like a task oriented. Or can you give me a high five? Yeah,
Okay.
this is like more task oriented.
Okay.
So we do this. So
Okay.
the client will know, they will be observing and they know, okay, this is will be functional. Okay. And this activity should be something meaningful.
Okay.
Okay. If like example, if you want to teach somebody to use the hand to eat, but they already got a caregiver who feeding them all the time, we are not going to achieve that goal because the client don't want to eat. Okay, it's only we want to train them. Okay, so that is one of the technique. Then we have like other techniques such as mirror therapy. We use a mirror, use the reflection of the other limb. Okay, uh, to use the to train the affected limb.
Yes, I have seen the
Yeah.
experiment on that.
Yeah. Nowadays, even words, we don't want to use like right hand, affected hand, weak hand. We don't want to use that kind of a word. So that register in client's mind, brain. So we just use your right hand, left hand like that.
Okay.
Okay, that is sorry. Yeah.
Yeah, yeah, it's correct.
So we don't want to use that kind of words anymore. That's why we choose our words. We don't want to say, "Can you put lift up your weak hand?" So we replace it with, "Can you just say right hand or this hand?" Like that. So we want to cut off that. We don't want to give them a feeling of that they are patient or they are affected.
Okay.
Okay, and then next one we use. We call it NMES, neuromuscular electrical stimulation, which is stimulate the muscle and it's produce the movement.
Okay.
Okay, another this one the worldwide. So everybody using this method is just like replaced with passive movement.
Mm-hmm.
Another technique is called CIMT.
Okay.
It's a constraint induced movement therapy,
Okay.
where we restrict the able hand or good hand, then we let them try to do a specific uh, movement or activity with the affected hand.
Okay.
So the four techniques we need to combine actually.
Okay.
Only these four techniques is now we have like a lot of journals saying that it's effective.
Okay.
Okay, both acute and chronic.
Okay.
So either we do two of it or we combine all these four and we create a program
Okay.
such as like upper limb, we divide into upper limb and lower limb, then we work on it. Like example, if they have a difficulty in walking, then it need gait training, balance, all coordination issues. So we put it as a lower limb rehab, then we work on it. All these four.
Okay. The last one you said, it
Mm-hmm.
seems to it really triggers. Like I
Mm-hmm.
really want to know. I'm interested.
Mm-hmm.
What? How do you? Can you give me an example? How do you actually do it?
Which one? Sorry.
The CMT,
CIMT.
CIMT.
Previously it was I induced movement therapy. Now it's become a constraint.
Okay. So how?
Sorry. It used to be CIMT, constraint induced movement therapy. Now it's become modified.
Okay.
They modified the timing because the in CIMT it more long hours, almost 12 hours. The
Oh.
clients they need to do the whole day.
Okay.
8 to almost 10 to 12 hours or
Okay.
10 to 8 hours, like long hours. Now
Mm-hmm.
we should make it short, like 4 to 5 hours. Sorry, physiotherapists, I might tell the timing wrong, but that's it. But currently we are using modified CMT. Remember that.
Okay.
So
So good information. Okay.
yeah, the timing is actually the timing. In modified CMT is 4 to 5 hours maybe. Then
Okay.
another one 8 hours. We just let them, for that they need to have some movement, active contraction of the muscle. From there we develop it.
Okay.
So we constrain the other hand, we can
Mm-hmm.
use glove. Nowadays there is a lot of gloves. Those days the therapist used to wear, the kitchen glove where you used
Uh-huh.
to take from
The blue
the
one, is it?
now they're using the blue one. The previously
Okay.
is for the one they use in the kitchen, the chair for, when they bake, they used to carry the
Ah,
tray.
mittens.
Yeah, mittens, right? They
Yeah.
use that. But now we have like a glove, right? Even nowadays, there are some robotic instrument like affordable one which can move the hands, just
Mm-hmm.
attach. They still can do, but why why these four techniques is important and how it's different from the others. Other techniques are like passive movement. um, you know when you just doing without involving the client, the neuroplasticity won't happen.
Okay.
We need to give them some challenge. We need to have some challenge for the brain to learn. Example, if now I give you like maybe form one maths. I don't know, are you good in maths?
No.
Okay, then
No.
we pass that. Maybe in English, or if I give you this, like tarikas maths, right?
Okay.
So you don't want to learn that, and brain already know that. So
Mm-hmm.
for the brain to learn, you need to have the challenge, must be
Okay.
there. Then only the neuroplasticity will happen. Another one, you must do it. Everything is from. So the four techniques I told you, like task orientated activity, um, mirror mirror therapy, and modified CIMT,
Mm-hmm.
and also EMS, all will make the stroke survivor actively participate in this treatment. Those who are doing this will get better recovery compared to those not doing this. Example, it's so sad, like to see some therapists let the stroke survivor on a bicycle. Like, why you want to do that? Stationary cycle. So why you want to do that?
Mm.
They'll say we want to improve the cardio. See, it's a neuro rehabilitation. It's a neuroplasticity. It won't help. Like
Okay.
even like example, if like why the cycle won't help? It might help the cardio, but not for the neuro, because when you move one leg, right, one side, the other leg going to follow. Then how the brain going to learn?
Okay.
So I don't know, unless any therapist want to debate about this.
Maybe we can do that in the
Yeah.
next podcast.
Okay.
Okay, so
Yes.
for the last
Back to you.
question, how do you assess the patient's recovery?
Okay. Neuro assessment is one of the
Yes,
thick.
in medical way
Yeah.
also, I think it's a
If you
very
go,
difficult one.
yeah. So even like KKM have the shortest version, but even that you need to do a lot of
Yes.
assessment, and it will take almost 2 hours
Mm-hmm.
to complete all the sessions. Everything, because we need to check every single nerve and their whether is intact or not intact.
Mm-hmm.
The But back to for rehab. So
Mm-hmm.
what the rehab is to make the patient independent.
Okay.
So like if me, I will cut it short. I'll straight away I will say like three goals. What is the client wants? Okay,
Mm-hmm.
that is one. And second, what is the family or caregiver wants? And the third, the therapist, we have our own goal. So, and all of this must be achievable,
Mm.
realistic and achievable. If
Okay.
it's not realistic, it's better to tell them no, we can't achieve that.
Okay.
Okay. So if it's achievable, then we tell them, then we work on that. Then we will tell, okay, we're going to do like this. This is the program, and we will work on it. And we need your support, your motivation to work. So
Okay.
assessment, we will, if some, it's better to do all the assessment. At least the therapists know what this stroke survivor can do, cannot do, and what you need to work on it. Like
Okay.
example, we have motor recovery
Okay.
and sensation,
Yes,
sensory,
correct.
right? We have stroke survivors who like 98% achieve motor.
Mm.
That means they are fully able to
Able
use
to
their hand, but they still have that sensory.
sensation.
They will feel numb. Do we really need to work on it? It depends on the
Patient.
person, right? But for us, we want to push them motor first. So because we scared if we can't achieve that, maybe it will prolong, the time. Because of course, it's a financially going to, cost the stroke survivors. So we tried our best. So we tried. That's why we go for like me personally, I will push for motor function first.
Mm-hmm.
Let them get the muscle or movement. Then after that, we'll focus on sensory, because sensory going to take long time, and the training also will be very boring.
Okay.
And both the therapist and and the client might be sleeping,
Okay.
snoring already, because he's going to, like example, I'm going to do this for like, or we can use different materials. It's going to take a lot of times, and
Okay.
it's also like if the client's goal, they achieve the motto and now they want to work on the sensory, then we work on the sensory.
Okay. For those who don't know, sensory is the sensation part. You feel it. So motor is the movement part. So you
Yes.
can move. Okay. So
Okay.
yes. So it really. So the first thing that we would want to work is the motor part,
Yes.
and then the sensory part comes in.
And also, we will always start with the low limb first, because larger muscle
Independence.
group, and also we can get it faster
Okay.
and it's easier compared to upper limb, which is like small muscles group and too many components. So we'll try to push lower limb first, but
Mm-hmm.
back to what the the client wants. If like, don't waste time on doing everything, or just focus on cardio, or the one who not really the client wants.
Okay.
Mm-hmm.
So it is back to what the clients want
Yeah.
and what is the achievable goal.
Yeah, it's also must be realistic.
Mhm. Realistic. That's
Mm-hmm.
very important.
Mm-hmm.
Okay. Anything else you would like to share with us?
For current, our local stroke survivors, Malaysian government has announced like they are eligible for OKU card. So you can apply for a OKU card, and you can get like I don't know what is the it's based on government's decision what help they will receive, but for me like someone getting a OKU sticker is also a big support, from some of them no need to walk so long.
Yeah.
So, they at least can use the OKU sticker.
Yeah.
So don't think as it's like we are
Stigma.
as orang kurang upaya. So but is a benefit. You still can get
Yeah.
something of it. So, and those who don't have that sticker, please don't park at that OKU parking. Right,
I
that's
know
from
you are
me.
you are very particular about that.
Yeah. So
Okay.
hopefully government also do something for those who are parking, you know. I
Illegally.
think yeah, it's not illegally like a normal person using a OKU.
Yeah, it's
Okay.
actually it's not right. So I think the person who deserves it, who needs it, supposed to be
Yeah, and
parking.
also another scenario. Example, okay, this person driving a OKU person.
Mm-hmm.
So the driver is a normal person. Can they park at the OKU parking?
I don't think so.
Yeah, right. But now the people are still like taking it, as just parking it there.
Mm-hmm.
Or sometimes they want to. This happen always. If you see always in front of banks,
Mm-hmm.
they will not just park at the OKU parking and they go inside the bank. So
Okay.
doctors, please do something on
Oh
this.
my God, what can I do? Okay, I had a wonderful session with you. Thank
Mhm.
you so much for coming. Maybe we should have another session.
Yes, definitely,
Okay,
doctor. Thank you
thank you
so
so
much
much.
for this wonderful opportunity. I shared as much I can. Thank you again.
Thank you. Bye bye.